My name is Joanne Kotsopoulos. I'm a scientist at Women's College Hospital, and along with Dr. Kelly Metcalf, we've put together this series of talks to talk about different issues in the management of hereditary cancers. So today, we're very excited to have a longtime colleague with us, Dr. Danny Vesprini, who's a radiation oncologist that treats prostate and breast cancer at the Sunnybrook Odette Cancer Center in Toronto, and is an affiliate scientist in the biological sciences at Sunnybrook Research Institute, and assistant professor in the Department of Radiation Oncology at U of T. His research focuses on the genetic predisposition to aggressive prostate cancer. He is one of the principal investigators of the Sunnybrook Active Surveillance Program and the director of the Male Oncology Research and Education, or MORE program, which focuses on men at an increased risk of developing aggressive prostate cancer, including those with a genetic predisposition such as a BRCA1 or 2 mutation. He is also the principal investigator of several ongoing clinical trials treating prostate and breast cancer with radiotherapy. So we're very happy to have you here, Dr. Vesprini, to talk about whether the BRCA mutation impacts your risk of developing other cancers. And just to quickly remind everybody, or those who have never participated before, feel free to type in your questions in the question box at the bottom of the Zoom link here. And then at the end, Dr. Metcalf and I will help navigate these questions for you. So take it away, Dr. Vesprini.
Thanks very much. It's always a great pleasure to be involved in these, so I appreciate the invitation. Yes, I have been a long-time member. In fact, I worked with Dr. Stephen Narod before I was in medicine, so this is decades old, and it's probably really been instrumental in helping me develop the program that we have ongoing, some of which I'll talk to today, and in my interest both academically as well as clinically. So just one disclosure is that we couldn't get the aspect ratio to work on my presentation, so we're gonna have to go through it in this mode. So I'm gonna lose some of the fancy bells and whistles that we had. Just a few disclosures. One, on the bottom in particular in regards to this slide deck is a combination of some of my slides as well as Justin Lorenz, who's a genetic counselor who co-leads this program with me. So I've stolen some of his slides, full disclosure. So, I think maybe the title was misleading, and I hope people aren't disappointed. Obviously, a lot of the cancers that we talk about other than breast and ovarian cancer are not male specific. A lot of the research I do is in male specific risk factors and risks for men with BRCA1 and BRCA2 mutations. So we'll talk about in general the risk in BRCA1 and 2 cares, male breast cancer, pancreas cancer, skin cancer, and then focus a little more on prostate cancer, as I'll show you that that's really the main risk that we have for men with these genetic backgrounds, and some of the ongoing research that we and others have been doing. So I guess what are the risks? I think it's not a surprise to anyone that's probably watching this that the risk of carrying a BRCA mutation is the same for females as it is males in family. That's something that information is changing. If you talk to me 10, 15 years ago, it was very clear that people didn't understand that. I mean, GPs didn't understand that. They didn't worry about the guys in the family. It was all about women for good reason. And we'll go a little bit through that. Definitely the knowledge of the risks of developing cancer in women is much more than that knowledge in men. And then that's multifactorial for that. And if you look at some recent data in the US, women are 10 times more likely to have been tested for example, BRCA1 or 2 mutations. There's other genes, of course, as well, in a survey than men. So women are far more likely to get tested. And that is something, though, that is slowly evolving. So what do we know about men? Well, men historically did not get tested routinely. Even when I started this program almost 10 years ago, the most common reason men got tested is because they had daughters. And again, I think that that's very justified and understandable. And mainly because there was uncertainty regarding what the cancer risks were for men. It really wasn't until the late 2000s, 2008, 2009, where the data started to come out to suggest that, oh, like, man, but these guys actually have risks and there's something we may need to do about it. There's a lot of lack of knowledge of the inheritance of the BRCA genes through men. We still see that now, where I don't think men understand that they can get a BRCA mutation through their mother, through their father. Again, it's thought that the lineage, historically, people think the lineage is through women, where obviously that just is not scientifically sound. And it is the dynamics of male and female members in families is something sometimes a challenge. Female carriers are far more likely to communicate results to their female family members, and males are less likely to discuss it with other members. I see that now when I see men with a BRCA1 or 2 mutation who maybe just got diagnosed with that. They say, well, I better go tell my sisters. And it's like, well, you should tell your brothers too. So I think it's still something that we have to fight a little bit. And ultimately, men are very poor advocates for their health. I think everyone on here who knows a man or is a man knows that we're really bad patients. And this is a little ad that was taken from colorectal cancer screening. But the ad being that, you know, thousands of men die of stubbornness because they just choose not to be screened. So if you look at actual cancer risks, and this is across the board, and this is just a gestalt of things, you know, compared to the general population, men and women with BRCA1 mutation are far more likely to get breast cancer, prostate cancer, and pancreatic cancer. Melanoma, there's some debate out there. But the real concern, of course, is prostate cancer, based on the fact that the number of men that will get it is higher. And as I'll show a little bit later, the prognosis of men that get it is unfortunately a lot worse. So breast cancer, I think that this is very superficial. Men have breasts too. You know, we did a study in collaboration with Jillian Einstein, who's you know, one of the big professors downtown, looking at psychosocial aspects of care, and particularly prostate cancer in general. But it's very interesting to see how men view their breasts. Guys don't like calling them breasts; they call them chests. But men have breasts. Men have fatty tissue, they have glands, obviously not as developed as women, so there is a risk of getting it. In the general population, the risk of getting breast cancer in a man is less than 1%. It's a little bit more than 1 in 1,000. If you have a BRCA1 mutation, that risk goes up to about 1 or 2%, depending on other risk factors, including family history. And men with a BRCA2 mutation can have up to 8% lifetime risk of getting breast cancer. So it's something that approaches a percentage where screening actually should make a difference. And what do we do for screening for men? It's mostly physical examination. You know, you feel a lump or bump on the breast or in the arm, changes to the skin, you get roughness, dimpling, bleeding, changes to the nipple, redness, scaling. So these are the things that we would typically look at from a physical exam point of view. If you look at men with breast cancer, if you compare stage for stage, men do as good as women. There really is no difference. The issue is that men are usually diagnosed later with more advanced stage, either because, you know, no guy looks down and feels a lump and thinks it's breast cancer. They think it's a cyst, or the skin changes nothing. And I think that unfortunately is also true for physicians that are monitoring guys. So, you know, I treat breast cancer, and I have a particular interest in men with breast cancer, and we will see guys that come in that, you know, felt something, and their GP said, oh, it's nothing, it's probably just a cyst. And, you know, and the problem is that you tell a guy it's nothing, and then 6 months later it could be like 3 times the size, and in his head it's nothing. So I think it's one of those things where we see them later because they become more advanced before they go back to their family doctor, and family goes, oh my God, what's that? And so although they do as well if they're caught at the same time, they tend to be more advanced at the point where they're picked up. And there are known genetic predispositions to breast cancer in men. Of course, BRCA1 and 2 being the most common that we hear of. As I stated, the general population risk is about 1 in 800. If you look at men with a BRCA2 mutation, the lifetime risk can be as much as 50 times that of the general population. For men with a BRCA1 mutation, it can be about 10 times the general population. And there's a couple other genes that are becoming more, we're becoming more aware of: PALB2, CHEK2, those men with XXY, so 2X chromosome 1Y, commonly known as Klinefelters, have an increased risk. But predominantly the risk is men with a BRCA1 or BRCA2 mutation. And if you look at what the recommendations are for screening, this, you know, the other thing we talked about is just what happens in common practice. But this is through the National Comprehensive Cancer Network, the NCCN, which kind of gives the big guidelines that we use probably around the world. The recommendation is that if a man has a BRCA1 or BRCA2 mutation, that breast self-examination education starts at 35, with clinical breast exam with a practitioner, usually a family doctor, starting at 35. I can almost guarantee you that doesn't happen in the vast majority of cases, probably on both ends in regards to who's the reason. And then start to consider annual mammograms for men with gynecomastia, so for some type of breast growth, usually fat or glandular growth, which can be seen on imaging. We can usually feel it on examination, starting at 50 years, or if that person has a family history, 10 years or earlier than the earliest known male breast cancer in the family. Again, this is something that is not happening quite often outside of large organized clinics, such as the one that we have at Sunnybrook. So anybody in this group that has experienced pancreatic cancer in their family, it's a horrible disease. You know, the pancreas is a gland that sits right in the middle of the body. It's not something you can feel, really doesn't have any symptoms or signs. So unfortunately, when it's found, a lot of times it tends to be really advanced. That in combination with it's just a very aggressive cancer, even when it's small, is horrible. And the life expectancy of people diagnosed with pancreatic cancer, unfortunately, is quite short. Thankfully, it's pretty rare in the general population, with less than 1% of people getting it. But if you look at men and women with a BRCA1 mutation, that risk can be up to 3%, depending on other risk factors such as family history. And with a BRCA2 mutation, it can be as high as 7%. So a 7% lifetime risk of developing pancreatic cancer. So something ideally we would be able to screen for. The issue is that there's not a lot of great screening. I think Steve Gallinger, who's again one of the big researchers and physicians here in the city, has done a study looking at different screening programs for people at increased risk of pancreatic cancer, and nothing's really been shown to have a huge advantage. That said, the NCCN does recommend to start considering pancreatic screening. Ideally, there's a lot of words. I know people may not be able to read it all, but it should be in high volume centers, ideally under research conditions, so that we can get more data to see what's effective. That screening could be MRIs, ultrasounds, blood work, and it really should be fine-tuned to those people you think are at risk. And in the little red boxed area that, those with a known predisposition, there's multiple genes that we know can increase risk of pancreatic cancer. We should start to consider screening at age 50 or 10 years younger than the first person that got pancreatic cancer in the family, and anyone that has a first or second degree relative. And that's something that's new. That's only been, I think it's only been up in the last year or so that recommendation has been up. And it's unclear how that's going to roll out, particularly in Canada, where the system is pretty stringent in regards to what we're allowed to order. But it is something that we're actively looking at, and I think hoping to increase, because it's a small group of people, so I think it's a justifiable thing to do. The last one before we get to prostate is skin cancer, so melanoma. So, all those that are aware of it, tends to be asymmetrical, weird-looking moles with scalloped borders, not regular, nice round mole that a lot of us have. I can put on my face right here. Different colors within the mole, evolving over time and increasing in size. So those are things that we look out for melanoma. Very common. In general population, 1 to 2%. Obviously, there's lots of risk factors for it. Most involve the sun. It's controversial whether those with a BRCA1 mutation are at increased risk. Some studies suggest that they are, some suggest not. If you look at BRCA2, it does seem to be a little bit more into that probably is. Getting an increased risk in regards to percentage is difficult because melanoma is very common. So you have to huge stats engines to figure out what the difference is between 2% and 3%, but it looks like it's higher. The majority of hereditary melanoma, though, is not with BRCA1 or BRCA2, it's with CDKN2A, which is the majority of familial cases. But it's still something I think is worth considering in BRCA1 and 2 families. So screening prevention, prevention is the easiest part. 90% of the cancers are because of this exposure to the sun. We have the second highest rate of melanoma in the world in North America. You should avoid the sun, wear sunscreen, wear shade, don't be a beach ape. There's a lot of indoor tanning, and it amazes me that that's something that's still allowed. But yeah, it's a very high percentage of people that are using tanning beds still. So I think the screening is more challenging, whether or not it's worthwhile being seen regularly by a dermatologist. It is something that we offer to people that increase risk, but it's not something that's been shown to provide a big advantage, again, because the numbers are relatively small. So getting to the prostate, I think that people are becoming more aware of this based on, I think, awareness and culture changes in regards to acceptance and comfort with cancer. But the prostate's just a gland that sits between the bladder and the rectum in a man. It is a gland that produces enzymes. That's why it's called a tubular alveolo-exocrine gland. Essentially, it provides a fluid which reduces the acidity of the vaginal tract, so that prolongs the life span of sperm. And it produces PSA, which is the common blood test that we use to monitor men for prostate cancer. And this is just an enzyme that allows the semen to swim throughout the seminal coagulum. So it loosens up the juice so that the sperm moves around, and obviously is very important for procreation. So the issue is that I think, I'll bring a little data up, is that it became quite apparent in the mid to late 2000s, like 2005, 2007, that men with a BRCA1 or BRCA2 mutation that developed prostate cancer tended to have like a lot worse prognosis than expected. It appears to increase the risk of getting prostate cancer. The lifetime risk for a man in the general population is around 8 to 10%, depending on who you believe. Men with a BRCA1 mutation may be a little bit higher, about 16%, whereas men with a BRCA2 mutation, that lifetime risk of getting prostate cancer is greater than 30%. You can easily make the risk of getting prostate cancer higher by screening people. Certainly the risk of getting prostate cancer in Canada is much higher than getting it in Uzbekistan, because we do PSA testing and we have a healthcare system. That doesn't mean that we do any better or worse than people over there. But the striking thing is that prostate cancers in BRCA1 and BRCA2 mutation carriers, compared to the general population, occur at a younger age, are far more aggressive, with a much poorer prognosis. So this is not necessarily just a risk factor. There are some genes that we know increase risk of getting the disease, but we don't know whether that actually changes anything. Certainly men with a BRCA2 mutation, it's very clear now that that is a very poor prognostic sign. And men with that prostate cancer with a BRCA2 mutation in particular do, unfortunately, quite poorly. And these are the two big studies, I think, that really cemented that. The first one that you'll see on the left was a study that came out of Iceland that showed that men with a BRCA2 mutation had a very poor prognosis when they had prostate cancer. So this is just a curve of survival, so prostate cancer specific survival. So as this goes down, people are dying of the disease you're looking at, in this case, prostate cancer. And when we tell people something, there's the median survival, that means the point at which 50% of the people that you're following have died or have met whatever outcome you're looking at. So for example, in this curve here, the median survival of men with a BRCA2 mutation that had prostate cancer is only about 2 years, and which is dramatically different than those that did not have a BRCA2 mutation. Now, this study has always been largely in the back of our head. There's something not quite right going on in Iceland, because men that did not have a BRCA2 mutation, which is the upper graph, upper line, their median survival was about 13 years. And that's less than you'd expect, because the truth is that with prostate cancer, you never reach the median survival because half the guys don't die of the disease. So there's something about that data in Iceland that is a little bit worse than expected. So, but I think that what was, at least to those of us that have been following this, became a bit more apparent that this was a real issue, is when Dr. Narod and his team put out that paper in 2008, which is the right panel, which showed that men with a BRCA2 mutation in their big databases, so men and families that had a BRCA2 mutation or a BRCA1 mutation, and looked at prostate cancer, again, specific survival, the darker is the BRCA2, the median survival of these men was about 5 years. So again, that is a lot different than you would expect for the general population. And with the BRCA1, it was in between about 9 or 10 years. Now, I've kind of put this green line up here, which is every epidemiologist's nightmare. You're not allowed to add lines to a graph, but I've kind of estimated what, in my mind, what the general population would be. Most men do very well for the first 5 years, and there's always going to be about 10 to 20% of men, if you follow them long enough, that were diagnosed with prostate cancer that will die of the disease. So the green is what you'd expect. The two lines below are men with either a BRCA1 or BRCA2 mutation, so obviously not doing as well as expected. So this is just putting together kind of a couple of those tables. If you look at the general population, and let's say at 10 years, you'd expect, at most 9 or 10% of those men to have died of prostate cancer. Looking at that data, if you went with a BRCA1 mutation, about half of those men will have died by 10 years, and guys with a BRCA2 mutation, 3/4 of the men will have died of prostate. So this is a real cancer. This is not as bad as pancreatic cancer, but you have more than half of the men dying of disease, despite the fact that we have this idea that prostate cancer is it's a cancer you're going to die with, not of, which just isn't true for men, particularly with a BRCA2 mutation. And the theory is that I don't think that BRCA1 or BRCA2 make prostate cancer. I think that prostate cancer is very common. And if a man lives long enough, he's going to get it. If you do autopsies on men in their 80s, 80% have prostate cancer. The issue is that every cell in a person with a BRCA1 or BRCA2 mutation, you only have one functioning copy of the gene. And of course, we know that the BRCA1 and BRCA2 genes, which make the BRCA1 and BRCA2 proteins, are integral to DNA repair. So essentially what you have is prostate cancer that's developing anyways, and then you have all of those prostate cancer cells only have one functioning copy of that very important gene that translates into a protein that repairs DNA. So if you lose the other gene, which we know happens in aggressive cancers, they kick out BRCA1 and BRCA2. Now you have a cell that can no longer repair DNA efficiently, so you develop multiple mutations and you become aggressive quicker. So the reason BRCA2 has double the risk of getting prostate cancer than the general population is not because they developed it at double the risk. It's because it becomes clinically apparent much quicker, whereas the average guy would never even know he had the cancer. Whereas a BRCA1, maybe a BRCA2, it becomes clinically relevant. PSAs go up, they have aggressive disease, and unfortunately that ends up becoming younger age with a poorer prognosis. And this is, and I apologize if anyone has seen me present this before, but this is my very simple analysis, analogy in regards to what this loss of heterozygosity. So loss of heterozygosity means that you normally have two functioning copies of a gene. When you inherit a mutation in BRCA2, for example, you only have one functioning copy, that's okay. When you lose the other copy, that's called loss of heterozygosity. You no longer have one on and one off, you have both off. So I liken it to my little Lego guys. So, you got a town that has two fire trucks, which it's good to have redundancy, right? Because you got a big town, you can have more than one fire. So those that have a BRCA1 mutation, they're missing one of the fire engines, but that's okay because, Buddy and his pal beside him there, they're fine. They can go in, they can put out the fires if they happen. The problem is if you develop loss of his heterozygosity, you've lost both the fire engines. So you've lost both copies of BRCA2. Now you can't put out the fires, but that's okay because there's no fires right now. The problem is once there's a fire, then there's a problem. And if you have no functioning copy of BRCA2 or you have no fire engines, the fire will just keep getting worse and worse. And that's why the disease becomes more aggressive. But the data, for example, from Dr. Narod previously was based on these old big databases of all the families he has. And that's probably a bunch of guys that were before PSA screening, before awareness. They didn't even know they had a mutation. What about if you look at guys in the modern era? So men that have been screened for prostate cancer, so presumably picked up a lot earlier than those that didn't get screened. They were being picked up because they got a big lump in their prostate or something else. So Dr. Akbari, Dr. Narod, and Dr. Nam, who's here at Sunnybrook, did a study looking at a screened population, so a group of men who had PSA tests and biopsies because of it, were found to have prostate cancer. So in the majority of them were very early. And then what they did is they went back and looked at all those guys, looked at BRCA1 and BRCA2, and compared how men did that end up having, for example, a BRCA2 mutation to those men that didn't. And what they found was that even when guys are picked up early, men with a BRCA2 mutation do worse than the general population. In their study, at 12 years, about only 60% of the men were still alive without dying of prostate cancer, compared to 94% in men that didn't have a BRCA2. So that's better than the data that I told you before, but it's still worse than you'd expect on the guys that didn't have a BRCA2 mutation. And this was kind of confirmed by another study in the UK. So Dr. Rossi Eels is another big researcher in looking at BRCA1 and BRCA2 for prostate cancer. And what they showed was, if you looked at all the people that have been treated, so this is not just detected, this is like a whole group of people that were treated with curative, so completely localized curative prostate cancer. You don't cure everybody, but a high percent should be cured. And then they compared those men that have BRCA1 or BRCA2 mutation, they lumped them together, to those that did not. And what they showed is that carriers had inferior outcomes compared to those that were not carriers. It didn't matter if they had surgery or had radiation. And the likelihood of having metastatic disease if you were not a carrier at 10 years was only 16%, which is about consistent with what we see in our data in North America. But if you were a BRCA1 or BRCA2 mutation carrier, it was 50%. So much higher chance of having aggressive disease, despite the fact that they were being approached up front with a curative intent because they were localized. So putting that together in my little makeshift graph, this is the older data, guys with a BRCA2 mutation compared to the general population. The 10-year survival was only 25%, so 75% of those men will have died, whereas in the general population, it's 90%. If you look at the screened population, looking at those two studies, it's better. But it's still not as good as expected. Everyone does good at 5 years. Prostate cancer treatments are incredibly well defined and huge advances. Even with really bad disease, men live for 5 years or more because of hormone therapies, new drugs, radiation, surgery. 10 years, you start to see people unfortunately dying of the disease. And then at the 15-year mark, although they don't have that data, they're only doing it to 12 years, up to 40% of men will have died of the disease. So again, we're doing better. Screening seems to help, but it's not as good as expected. So it's not just a matter of finding it early, or at least finding it early what we consider to be early. We have to find it earlier or find new ways to do it or new ways to treat. So what do we do now? So ideally, men with a BRCA1 or BRCA2 mutation are screened. We have specialized clinics. I have one at Sunnybrook. We call it the Familial Prostate Cancer Clinic. It was officially established in 2014. I had started seeing people with these mutations earlier, but it kind of became more formalized at that point. We offer screening starting at 40 years old. History and physical examination, of course. We do a digital rectal examination once a year, PSA blood test, that's this prostate-specific antigen that gives us a sense of what's the likelihood someone has disease. There is a study with Rossi Eels in the UK that shows that PSA screening is more effective in those with a BRCA1 or BRCA2 mutation. So there's a lot of hubbub about, PSA testing doesn't save anybody. It is better. People at risk do benefit from it. We start to discuss mammography at 50 years old. As per the NCCN guidelines. We discussed dermatology referrals. Definitely those that have a family history or have a skin type that looks like they're at risk of having melanoma. We discussed pancreatic screening blood work, maybe an MRI. It's a bit controversial right now, especially in the Canadian system. And then men are followed clinically in that program, and they're offered inclusion into our academic cohort, which is called the Male Oncology Research and Education, or MORE program. We follow all men at increased risk of cancer, so men with a known genetic predisposition, men from the Caribbean or Western Africa, and those with a very strong family history. We bag blood, we bag their tissues. If we get them, we have a big database, and we do ancillary studies around those to try to get a sense of who's at risk and who's not. So the more enrollment, so we have 599 guys, and I saw 3 this morning, 2 of which agreed, 1 wants to read it. The majority of these guys are men with a BRCA1 or BRCA2 mutation, so 304 of those men. We have a smattering of other genetic predispositions in genes that we think increase the risk of prostate cancer in particular, and then a whole cohort of men either with a family history or African ancestry, and there's a group here that not put into the numerator are guys that have very early onset prostate cancer, which is a separate cohort that we look at, so guys in their 30s or 40s that develop prostate cancer. One of the studies that we're close to finishing is an MRI screening trial. So remember the previous data show that even if you screened, which is a digital rectal examination and a PSA test, guys do better than than they did back in the old days, but they don't do as good as people that don't have mutations. So maybe we need to do more. And so this study is looking at MRIs to see whether or not an MRI guided biopsy improves things. It's for men that are 50 or above. Doesn't matter what their PSA blood test is. This has to be willing to have a biopsy. MRI is done, then we do a standard biopsy like we normally would do. And if there was a target, if something was in there that we were worried about, we stick extra needles into the target. We take extra cores and then we're trying to determine whether or not MRI is a valuable screening tool for these men. So to date, we have put 42 men into the study. 31 so far have had the MRI and the biopsy. Some guys are in the queue because we batched them. Some guys had the MRI and then bailed, which is their prerogative. So of the men that we've gone through, 17 of those patients have what we call an MRI target. So a lesion that's suspicious for maybe being prostate cancer. Of those, 7 were. 3 of those were low-grade disease, the type that we normally would watch, but I don't know if it's safe to watch this. 2 of them had what we call intermediate risk disease or intermediate grade. That's the type that we do treat regardless of genetic status, but I think perhaps we need to treat men with this genetic background a bit more aggressively than the average guy. 2 of those men had very high-risk prostate cancers, which got treated very aggressively. So when you look at this data, the positive predictive value of the MRI, so the odds that there was cancer there, if we thought there was something there on the MRI, was only 41%. That's not bad. It's not great. That could improve. Of the 14 patients that didn't have an MRI target, remember, they all get a biopsy regardless. None of those men had cancer. So the negative predictive value, the likelihood that there's cancer there if the MRI was negative, was 0. So 100% negative predictive value. If it's negative, it's negative. Now, this is a small sample size. Statistics that wouldn't kind of pan out, but it's a good early sign that the MRI picks out the guys that need a biopsy, and the other guys you can probably just keep watching. So far there's less cancer, so that's good. We expected to have more than this, quite frankly. The MRI hasn't missed any cancers yet. That's very good. We still have to biopsy more than 50% of the patients. Prostate biopsies are invasive, so that would be ideal to get that number down. So you're really only biopsying the people that really need it. This study hopefully will support for routine MR screening. MR screening is going to change in the country, in the province soon. There's more and more data that MRIs should be done for guys that you're considering a biopsy before, because it avoids unnecessary biopsies. But that won't pertain for people that are 50 years old with normal PSAs. So hopefully this data, as well as some other studies are going around the world, will allow us to offer MRI screening to men for prostate, just like we do with women with breast cancer. And you only biopsy those with suspicious changes so that you pick the disease up as early as possible. Whether that's going to translate into an improvement long-term in regards to how they do, I don't know. That's the subject to more research, but certainly that's the best that we have to our ability right now. And then that becomes the gold standard in regards to other men at risk. So men from the Caribbean, men with CHEK2 mutations, men with very strong family histories of cancer that you can't pinpoint where it's from. So hopefully that will give more evidence to do that, because MRI is a very non-invasive way to screen people longer term. The question just is what do you do when you find these diseases? I mean, that's the one problem with prostate cancer. You find it really early sometimes, and PSA testing and screening has led to a lot of misery in this world, not because it's a bad test, it's because there's bad doctors. And people have treated people that didn't need to be treated for decades, and it still happens today. The question just is if you find a very early prostate cancer in a man with a BRCA2 mutation, is it safe to watch, or is it something you should treat right away? So getting to treatment, I think aggressive disease warrants aggressive management until you have those markers of who really is at risk and who isn't. So active surveillance, I run the active surveillance program here with Lori Klotz and Andrew Loblaw. And the question is whether a BRCA1 or BRCA2 associated prostate cancer, is it really low risk? If you watch someone with that disease, are you just allowing it time for the second fire truck to have the X mark on it, and then you're getting this aggressive disease later? I think that most of us at this point would, in a man that is a good surgical candidate, has no significant issues with surgery, that should be the first choice. I mean, if you look at the general population, 100 guys choose surgery, 100 guys choose radiation, there's no difference. Men can pick their poison. They're both fine. They both have a small chance of making you miserable. I think that, I'm a radiation oncologist. I treat people for a living. That's my job. This is my hobby. If I see a man with a BRCA2 2 mutation in particular, I usually push towards surgery because I don't know yet. Radiation theoretically should take advantage of having a DNA repair deficit like a BRCA2 mutation. So cells that don't have BRCA2 or BRCA1 are exquisitely sensitive to radiation because they can't repair DNA, and radiation works by causing damage in DNA. But the thing about surgery is you find out the truth, you get the full pathology. Radiation just assumes because you never get the sample. And there's some retrospective data that maybe surgery is better than radiation for men with a BRCA1 or BRCA2 mutation. There's a lot of confounders to that. If you go back and look retrospectively, there'd be things in there that you can't account for. But I think one of the things that we think is that one of the problems with radiation with a BRCA2 mutation, for example, is that you leave behind the gland. And if that gland is prone to making tumors, 5 years later it could make another tumor, and then you're stuck with the same problem. So maybe taking it out is, I think, worthwhile. I've treated men with radiation with a BRCA1 or BRCA2 mutation because either they chose to or their chance of dying of the operation was more than dying of the cancer, so it wasn't worth the trade. But for the time being, I think surgery is the standard approach, at least as a recommendation. Prevention, we always want to prevent things. I get asked quite regularly, should I have my prostate removed preventatively, just like the women in my family have their breasts removed? It's a big operation. There's a lot of risk to it. Risk of at least half of the men lose their erections the rest of their life. There's about a 10% chance of having leaking water. 1 or 2% chance of the leak of water is really bad. It's not crazy though. I think one has been done in Toronto. I think it was done preventively. There's some rumors that maybe he did have low-grade cancers. We have discussed it as consideration of a clinical trial. So Dr. Neil Fleschner, one of the big urologists downtown, also has an interest in genetics and prostate cancer. We've discussed that maybe he would open a trial to offer preventative surgeries with prostate removals in men that were willing to. I think it'd be good on a clinical trial to get data to see if it actually helps. Are there drugs we can use? I think a lot of people here might know what PARP inhibitors are. So they are a drug that inhibits the PARP gene, which is involved in a backup DNA repair mechanism if BRCA1 or BRCA2 aren't working. So I could bore you with this little schematic, but I like to make things simple because that's how my brain works. If you relate it to Toronto traffic, so Toronto traffic, for those of you that are in the area, it is the worst commute in North America. It's the second worst in the world. We spend way more time in the car getting to work than they do in Los Angeles and New York, Barcelona. The only one that we beat is Bogota, Colombia. There's about 6 million people that live in the greater Toronto area. Almost 1.7 million of them drive to work every day. So the two main arteries are the 401, which is above the city. About 500,000 people drive on that every day. And the other one is the Gardner Expressway, highway just south near the lake, which about 200,000 people use. So my analogy is for me to get back to my parents and my wife's parents' place, we have to go that across the city because we live on one side of the city and our parents live on the other side in a city nearby. So this is where you lose my little graphics. So this will look real nice. So what you see is, we usually go across the QEW. So with BRCA1 and BRCA2, single strand breaks are repaired. They happen all the time. And BRCA1 and BRCA2 are involved in something called homologous recombination, where the DNA is repaired efficiently, almost never have a mistake. If you do not have a copy of BRCA1 or BRCA2, which is noted down here, you can't use that pathway to repair DNA. So you have to go up to this PARP pathway, which is less efficient and causes more mistakes, but you can repair the DNA. Because if you don't repair the DNA, the cell dies. The cell can't live with broken DNA. So when I'm going home to my parents' place, I try to take the QEW, but if there's an accident on it, I will go up across the 401 and still get there. It takes me longer, but I get there. The problem, if there's an accident on the 401, I can't get there that way. I have to go through the city, and it causes a lot of road rage and a lot of swearing and a lot of F-bombs. But so that the analogy to that is that if you block the PARP pathway in someone that doesn't have a functioning copy, or a cell that doesn't have a functioning copy of BRCA1 or BRCA2, you can't repair the DNA that way. There's no other real way to repair the DNA, so there's cell death. And that's why PARP inhibitors are exquisitely, or BRCA1 or BRCA2, cells that don't have a BRCA1 copy or a BRCA2 copy are exquisitely sensitive to PARP inhibitors because now every little amount of DNA damage can't be repaired, and those cells will ultimately go on and die. So some of the other things that we're doing in our program, I mentioned a little bit about the collaboration with Michelle Scope and Gillian Einstein, the psychological effects of being a male BRCA carrier. We offer mammograms, so we have a subset of guys that we did questionnaires on in regards to what does it feel like getting a mammogram? You know, what were your thoughts? It's a very fascinating read. I mean, this is way out. I'm a molecular biologist guy. This was way outside of my scope, so I found it, like, you know, very interesting and enlightening being involved in that research. We have a big study open now looking at whether we can predict which cancers are more aggressive using BRCA1 and BRCA2 as the hallmark of what's considered to be aggressive. If you look at very aggressive tumors, regardless of if it's prostate, breast, ovary, regardless of whether you know that person has a BRCA1 or BRCA2 mutation, and you look at it at a genetic level, a lot of those very aggressive cancers will have no functioning copy of one or two of those genes. That's how it gets aggressive. So we have a study open where we're looking at these types of tumors to see whether we can find the evolution of the disease from normal prostate, for example, all the way to the aggressive type. And the other one is kind of blending my research in active surveillance as well as genetics. Is I have a cohort of men where I have all of their blood, so I can look at their inherited DNA, what we call germline DNA, and I can go back and look at a whole whack of genes, including BRCA1 and BRCA2, and see whether we could have predicted who did well on surveillance versus those that didn't. Because my thought is that any guy that gets prostate cancer that has a family history should consider having this gene test done. Because if you have a mutation in BRCA2, you probably shouldn't go on surveillance. Don't let that second fire truck get lost. If you have a BRCA1, maybe you can, but probably should be watching you a lot closer and be maybe a little more aggressive than we normally would. So this is a big group of people. Obviously, I'm just the spokesperson today, the pretty face. Justin Lorenz is the genetic counselor who co-leads this with me. The program would not exist without him. There's no doubt about it. Before he came, I was floundering. There's a group of basic scientists, oncologists, radiologists, Dr. Akbari, Dr. Nayrod, all together kind of build this program, which we've been really doing quite well. It's one of the biggest collections of men at a predisposition, a genetic predisposition to developing prostate cancer. So I think it's something that will continue to grow. And I think that's it. If people, I'm very happy to be contacted by email, Twitter, whatever people want to do these days, but there's just some links up there if you're interested.
Thank you so much, Dr. Vesprini. That was an amazing talk. And it's really quite outstanding to think about how far we've come since we started working together in the mid-1990s. I mean, we weren't even really thinking about—
I know, I was a teenager then, right?
Me too. And we weren't thinking about men. We were really focused on what do BRCA1 and 2 mutations mean for women. So,
and I think as in my talk, and maybe it'll come up with questions, but that really has been what our patients, our families, us. It was kind of that I think that study from Stephen where it really showed that men with BRCA1 2 doors, that was kind of the eureka moment.
Yeah. And so I think it's amazing. And I think that there is a clinic that's dedicated to taking care of these men is really noteworthy as well. So thank you for leading that. So we're going to open it up to questions, and I'll just share with the audience, if you do have questions, please type them into the Q&A, and Dr. Kotsopoulos and I will try to get through the majority of questions and group them if we think we can do that effectively so we can get through the majority of the questions. And there are some questions about screening for both pancreatic cancer and screening for colon cancer for BRCA1 and 2 mutations. So what are you currently telling your patients? What's available? Is it recommended that patients with a BRCA1 or 2 mutation have colon screening? What's available to men and women in Canada for pancreatic screening?
So colon is relatively easy because we recommend colon screening for everybody. So I think that we would recommend that. I mean, definitely if there's a history of colorectal cancer in your family, you know, we would probably go with the normal, you know, start 10 years before the person had it. I think that's a pretty reasonable thing. You know, there is some evidence that maybe there's an increased risk. I think for BRCA2 families in particular, and I think that's a study that you were involved with, Kelly, some time ago. with the group where, if you look at families, with BRCA1 and BRCA2 in particular, there's just cancers. They may not always fit a syndrome all the time, but you just see excess cancers. And that's probably speaking to the phenotype of the BRCA2 being a bit more integral in regards to repairing DNA. And therefore, if you lose it, you're more likely to have a cancer. So they may not all be breast, ovarian, and pancreas. You also get the weird and wonderful things that we think may or may not be involved. So colon cancer, we recommend colon cancer screening at 50. Talk to your family doctor. I think that's just the standard thing. Pancreas is the one that's challenging and controversial for multiple reasons. One is that it's still pretty rare, and it's very hard to get reliable data and prove that screening of something that may only have a 3% chance of happening in your lifetime is going to work, because you would have to essentially follow 1,000 people with yearly whatever you decide to do, MRI, scopes, for 20 years. And none of us we're all Pepsi generation. We don't have that kind of patience. B, no granting agency is going to give you that money. That's crazy. You don't contribute to the Vesprini Foundation because he says he's going to do something and tell you the answer in 20 years. That doesn't sound good. And it's expensive. So for example, MRIs are expensive, and there's a rate limiting issue, particularly in Canada. It may not be an issue in other countries where people can pay out of their pocket, but it is an issue. So we at Sunnybrook now, for men with this is men, right? I can't speak for the high risk program in women. If a man has a family history of pancreatic cancer, or he understands the risks of what we call false positives, so the test being positive when it isn't disease, we do something called CA19-9, which is a blood marker that we know is good for following people with prostate cancer, with pancreatic cancer. It's never been shown to be a good screening tool, but again, probably for the same reasons that you just can't prove it. It's just too hard to do. I have found one pancreatic cancer using this tool in our program. But that's, I've been doing this for several years, and Sunnybrook's a big hospital, and it's one drop in the bucket. The NCCN guideline now that we should start to consider yearly MRI is the one that I think is going to cause the most problems, because it's hard to get MRIs. I think it's a reasonable thing. For example, I have one of the guys in my program who has 2 people in his family that died of pancreatic cancer in their 40s. I mean, I just sneaked that one in. And I think but that's not that I can do it in everybody. It is something that I'm start to engage with radiology here. Ideally, we would have a system where guys have an MRI that covers both the pancreas and the prostate. If we're going to do it for guys, we have to do it for, not the prostate, we have to do it for women. So I think it is, and it's a small problem. It's not a large number of people, but I have 300. So I have about 180 guys with BRCA2 mutations. Probably half of those guys are 50 or above. The other guys are younger guys, so we wouldn't worry about them quite yet. That ends up being 50. And that's just the men. Women are way bigger. So I think these are some hurdles that we're dealing with, but I think it is something that we're working towards, because an MRI is non-invasive. It's if you find something early. I mean, I know someone in my family that found a very small pancreatic cancer by mistake because she had a problem, belly aches, they did an ultrasound, and she got cured of it because they found it so damn early, right? So, and that's the thing, is whether that would make a difference. It's just, right now, there's no clear way that we do the screening other than sneaking in those that we think may benefit.
Okay, so clearly there's a lot to be done with screening, not only for the men, but for the women, also for the other non-gynecologic cancers, and thank you. So we have quite a few questions coming from what seems to be moms in the audience, talking about when is an ideal age to have their sons tested. So maybe you can give a little overarching recommendation of what you think, maybe by mutation, BRCA1 versus BRCA2, and for age of testing of their sons?
Yeah, so I think that question is more about psychology than it is about biology, because I think that once knowledge of the mutation is made aware of, sometimes it's just a reasonable thing to consider doing. I think if you're talking about biology or intervention, we don't actually start screening until men are 40. So there's really no intervention prior to that. So the old thinking is that if you're not going to do something about it, why worry about it? The other biological reason, though, to consider it sooner is if they're considering family planning. So young men that are considering having a family, if they're interested in things such as pre-implantation genetics, then it's worthwhile knowing earlier so that you're aware whether you are or aren't a carrier of your familial trait. But from a screening point of view, we don't do it. So I've seen guys in their 20s that have it. I've seen guys, I saw one guy who was 19. And we give them information. This is the deal. These are your risks. Call me when you're 40. And I've had some guys call me when they turn 40. So it's okay. But I think that the family planning is more of an issue. We don't have any prevention strategies. We don't know anything else. So I think you don't need to know unless you need to know. But that said, my story where it's the psychology is important is I'm an oncologist, and I treat testicular cancer as well. And I had a guy who came from a family with a BRCA2 mutation, and he had testicular cancer, and I never knew he had that in his family. He told me, they said, "Oh, it's interesting." He's like, "Yeah, well, I clearly have it." And I said, "Have you ever been tested?" He's like, "Well, no, but I got a cancer, so obviously I have this gene." And I said, "Let's get you tested," and he didn't have it. And he's like, "I've been walking around thinking I have this thing because I had this testicular cancer." So I think sometimes doing it from a psychological point of view makes sense, so that A, you're not walking around thinking you have it and you don't, and B, you have it, you might as well know. So I think it really comes down to maturity when it comes to psychology.
And legally, it's age 18 would be the youngest, just in case some of you didn't know.
We have one last question that we can have time for, and I'm sorry we haven't been able to get through all of the questions today. It's obviously a very interesting topic for many people. So what would you recommend in terms of men having a BRCA2 mutation? I mean, you have this wonderful clinic that follows these men. Should men come and see you, or is it okay for them to be followed by their family doctor?
Yeah, selfishly, I want them all come to me.
No.
No, men
what
need
would be available to these men if they come to a specialized clinic as opposed to just
I don't do anything magical that family doctors can't do. I offer to follow guys from an academic point of view. It's important, but my finger is maybe a little bit better, a little more seasoned than the family doctors based on how many finger exams I do, but it's no better. So I tell all my guys that either live out of town or whatever reasons, talk to the family doctor. If this is not a debate, you need to do a PSA test every year. You need to have a digital record examination. If your family doctor says PSAs don't work, then you get a new family doctor. Because for people at increased risk, and I got in a Twitter battle with a bunch of family doctors about digital record examinations, and I kind of said, guys, I mean, like, because they're saying we shouldn't do it anymore, there's no value. And I was like, you want to debate PSA tests, okay, but a finger in the bum is easy. It doesn't cost anything. And the person that you find something is the one you save. The guy with a normal PSA, but something on the finger is the person that has bad cancers. And then they started like telling me I should look up active surveillance. Meanwhile, obviously, like, we wrote the papers. So I then decided it's not worth to fight these guys. But I think it's a PSA test. I mean, if being involved in an academic program is great, but it's not going to save their life.
Okay, so important for men to know. If you can't access an academic center, they need an annual PSA done and an annual digital rectal exam.
And I think the one thing about this for people that are listening that may have men in their family or men is that with virtual medicine now accepted, we are probably going to open up a virtual component to this where you can be anywhere and you get your PSA done in Moncton, and then we see you virtually, and allows us to keep the data and give you counsel, but not drive into Toronto. So that's going to really open up that for a lot of people.
That's great. Thanks.
That's definitely one positive after COVID. Access to care.
Yeah, that and well, you guys can't see it because the background, but now I know that I should never grow my hair this long again. The 80s are gone. The mullet no longer. I have a mullet. I got to pin it back. Yes.
Oh, that's okay. Well, Dr. Vesprini, we could go on for a lot longer, I'm sure, but we really appreciate your time and expertise and all the hard work you're doing, especially for the men, the male mutation carriers. And just before we end, there were some questions about whether this talk will be posted, and we do in a couple weeks post this in the Women's College website for you to review and share with your family members or friends. And also next month, Dr. Kelly Metcalf, who's here today, will be presenting an exciting webinar and be giving us an update on the treatment of BRCA-associated breast cancer and some emerging findings from her research program. So we thank all of you for participating and being here today, and we hope you've learned as much as I have today. And again, Dr. Vesprini, thank you again for your time.
My pleasure. It was great.
Thank you. Thank you to everyone for attending. We look forward to seeing you next month.